Good morning, everyone. So today's talk is based on OCT, how to use it in clinical practice, and I'll be covering important take-home messages. It's important to understand that OCT has become an important tool for the diagnosis of glaucoma, but the practitioner needs to remember important pearls and pitfalls before incorporating the machine in clinical practice. I have no financial disclosures. Now, whenever you are faced with a patient in the OPD, the patient will ask you a critical question: Doc, do I have glaucoma or no? And this is what you need to answer. And this is a challenge in patients with early glaucoma or glaucoma suspects. So, to make an early diagnosis of glaucoma, you need to document defects in the retinal nerve fiber layer and focal thinning of the neuroretinal rim before visual field defects are apparent. So these two abnormalities, retinal nerve fiber layer defects and focal thinning of neuroretinal rim, are the most important clinical skills you need to learn for the early diagnosis of glaucoma. So the first part of diagnosing glaucoma is to take a good fundus photograph, a color fundus photograph, or a red-free fundus photograph, and document the retinal nerve fiber layer defects. Now, often I have seen in clinical practice, our residents, they focus on the curve-disc ratio. So instead of focusing on the curve-disc ratio, you should start focusing on the striations of the retinal nerve fiber layer, which are normally visible, these white striations, and look at areas where there is a dark band, wedge-shaped defect emanating from the disc. So this is critical for the diagnosis of glaucoma. And in addition, you should screen the entire neuroretinal rim and look for focal defects in the neuroretinal rim and associated retinal nerve fiber layer defects. So before using the OCT, you should become a master of interpreting the fundus photograph and do a dilated 90D examination of the optic disc and the surrounding retinal nerve fiber layer. So if clinically you can diagnose this RNFL defect or a notching of the neuroretinal rim, then the OCT can be used as an aid or a confirmation of your diagnosis. If you are not able to detect any retinal nerve fiber layer defect and there is a perfectly healthy neuroretinal rim, then beware of any defects which come on the OCT. It may be false positive. So the first question is that is it essential to have an OCT in a glaucoma clinic for diagnosis or treatment of glaucoma patients? Well, the answer is no. The OCT is not an essential part of the glaucoma clinic. So what is important for the glaucoma clinic is to have a fundus photograph, a digital camera to document the optic nerve head and the retinal nerve fiber layer and carefully examine this. This is the most critical part of examination. So if you take a good photograph of the optic nerve head and study it carefully, you can make out, like in this patient, there are defects visible in the retinal nerve fiber layer. So if you look carefully at the fundus photograph, majority of the patients you will be able to diagnose glaucoma and you do not need the OCT of this for this purpose. So learn to focus on the retinal nerve fiber layer defects and see the distance of these defects from the surrounding blood vessels. So when you follow up the patient, you can measure the distance between the retinal nerve fiber layer and the major blood vessels. And if this defect expands, then you know close to the blood vessel that this patient has progressed. So clinically, you can both diagnose glaucoma and follow up the patient with the fundus photograph, and you do not require a OCT for this purpose. In this study, they showed that OCT did not significantly enhance the diagnostic accuracy of detecting glaucoma, and the additive diagnostic role is limited for glaucoma specialists. And this is if you have a proper training in taking and reading the fundus photograph with focusing on the retinal nerve fiber layer. So then the OCT did not enhance the accuracy. The retinal nerve fiber layer photographs were better. So the first take home message for the participant is that learn to take, read and interpret the fundus photograph like a radiology reads the MRI. So whenever we go with the MRI to our colleagues in uro-ophthalmology, they often tell us that we'll discuss it in a neuroradiology conference. So that is how you should approach a fundus photograph. You take hold of 2, 3 of your colleagues and then carefully run through each part of the optic nerve, the cup, the neuroretinal rim, and the adjacent peripapillary area and retinal nerve fiber layer defects. And you will be surprised at how many patients you will be easily be able to diagnose glaucoma by spending time on reading the fundus photograph, both color as well as red free. Another important thing that is available to us now is the multicolor image obtained on the OCT. So this has become very useful for the diagnosis of glaucoma. So this is a multicolor image obtained on the spectralis OCT. And here you can see the retinal nerve fiber layer defects have become very clearly delineated. You can see superior white striations, healthy nerve fiber layer, and inferiorly this wedge-shaped retinal nerve fiber layer defect is apparent. So sometimes this photograph has not come out well or the retinal nerve fiber layer defect is not apparent. Then always focus on the multicolor fundus photograph, and especially in eyes with chorioretinal atrophy, you can see the RNFL better with the blue reflectance. So these two images, the green reflectance and the blue reflectance, are very important, and you will see a highlighted retinal nerve fiber layer defect, which may not have been apparent on the fundus photograph. And here you have made a diagnosis of a RNFL defect and diagnosed glaucoma. And further on, you can move to the detailed OCT for interpretation. But this tells you the topographic defect that is visible on the multicolor image for a retinal nerve fiber layer defect. And this becomes slightly difficult in patients with myopic chorioretinal degeneration. And as I told you, use the blue filter, and that will show the retinal nerve fiber layer defect, which was not previously visible. Again, examples of the multicolor image in patients where the fundus photograph, the defect was not visible very nicely. But here you can see on the green reflectance and the blue reflectance filters, the RNFL defect has become visible. And here you can see a very narrow RNFL defect which has become visible on the multicolor image. So you are now sure that there is a defect in the retinal nerve fiber layer, and the OCT can go ahead and confirm this defect. But clinically, you've already made up your mind that there is a RNFL defect visible on the multicolor photograph obtained on the OCT. So why are we using OCT if we are able to diagnose glaucoma with a good fundus photograph? The main advantage is that for getting a high quality fundus photograph, you require a lot of training. And if you take 10 photographs, maybe one of them will be very clear. So this requires a lot of skill training to take, capture and interpret fundus photographs. And the optical coherence tomography provides us a very fast objective estimation of the optic nerve head and the retinal nerve fiber layer parameters. So these objective parameters are easy to document and follow up on the long term in the patient. And the additional benefit which you cannot pick up clinically is the ganglion cell imaging, which has become very important in recent time. So this is a benefit of the OCT, which is not possible on clinical examination to see the defects in the ganglion cell layer. If you want to see one major utility of the OCT that I have found in my OPD, that is to rule out glaucoma. So many of the patients are referred with these large cup disc ratio with a diagnosis of glaucoma, intermediate IOP 18 to 22. But once the clinician sees this large cup disc ratio, there is an alarm bell, patient has glaucoma. And here the OCT becomes very helpful. You can see absolutely supranormal, healthy retinal nerve fiber layer. So you can easily say that there is no retinal nerve fiber layer defect, and this is a physiologically large disc with a large cup disc ratio. So that is the main utility of OCT, ruling out glaucoma in patients with suspicious discs, especially large discs with a large cup disc ratio. The major problem arises if you have a patient with a large cup disc ratio and your OCT is borderline. So now you are not sure of the diagnosis. So this comes a major dilemma whether you should label the patient as glaucoma and start lifelong treatment. If there is a suspicious disc and the OCT is marked as borderline and you are not sure of the diagnosis. So here I want to point out a major limitation of all imaging technologies of the optic nerve and retinal nerve fiber layer, including the OCT. There is a huge variability of the shape of the optic nerve head, and the number of axons may vary from 0.7 to 1.5 million. Because of this huge variability, it is very difficult at one point of time to differentiate healthy eyes from glaucoma because the normative database is limited and the actual there is a huge variability. So if you are not able to differentiate in the first visit whether this patient is healthy or glaucoma, the most important message I want to convey for using the OCT is that actually when you use OCT, we are used to comparing the patient's data against a normative database. But the best way to use OCT and make a diagnosis of glaucoma is to capture the patient data as baseline and use that as a normative data and then monitor change over time for the patient. So instead of just comparing the patient to the normative database, you capture the patient on the OCT. That is the normative database for the patient at a point of time and follow up the patient and monitor change over time. So if the OCT parameters are deteriorating as compared to baseline, then you make a diagnosis of glaucoma and you're sure now that this patient has got glaucoma. In the initial visit, you were not sure and you just label the patient as a suspect. The next important question is at which parameters to evaluate on the OCT. So you have a lot of parameters available, the retinal nerve fiber layer, the macula thickness, the ganglion cell complex, the optic disc neuroretinal rim. You have also the OCT angiography, peripapillary macula, and lamina cribrosa imaging. So currently, the latter two, OCT angio and lamina, are not routinely used for OCT diagnosis, but you must be confident in evaluating the retinal nerve fiber layer, the ganglion cell complex, and the neuroretinal rim for making a diagnosis of glaucoma. So these three important structures are to be evaluated in any glaucoma patient. And this is important to understand because glaucoma occurs due to apoptosis of the retinal ganglion cells. So when you see the retinal ganglion cell, there are basically three portions. You have the ganglion cell body, and then you have the dendrites of the ganglion cell, and then you have the axons. So these three components can be captured by the OCT machines. You have the ganglion cell body, that is the GCL. You have the inner plexiform layer, the dendrites, that we label as GCL plus. And then you have the axon, the retinal nerve fiber layer, that we label as GCL plus plus. So for making a diagnosis of glaucoma, you can get damaged either in the ganglion cell body or in the axon, the retinal nerve fiber layer. So you have to do a comprehensive imaging of all three structures to pick up glaucoma at an early stage. the advantage of using the retinal nerve fiber layer over the ganglion cell clinically is that you can corroborate your clinical finding. There is a visible retinal nerve fiber layer defect that is confirmed on the OCT image. But this is not possible with the ganglion cell defects because they are not visible clinically in the macula. And that is one advantage of using the retinal nerve fiber layer, that you can clinically correlate the defect on the OCT with the fundus image, and you are sure that this is a diagnosis of a retinal nerve fiber layer defect. While with the ganglion cell, you only rely on the OCT. Clinically, there is no parameter to correlate your finding on the OCT. There is a special utility where the macular parameters are useful over and above the retinal nerve fiber layer. And this occurs in patients who have artifacts of the retinal nerve fiber layer, or there are congenital disc anomalies. When the retinal nerve fiber layer has reached a floor, that means there is an advanced glaucoma, and the entire retinal nerve fiber layer has already reached a level beyond which there is no progression. So here the ganglion cell can be used to assess progression. The macula is very useful to differentiate myopia from glaucoma because there is an artifactual thinning of the retinal nerve fiber layer. And especially in eyes with normal pressure glaucoma, it has been found that the changes in the ganglion cell layer precede the changes in the retinal nerve fiber layer. A word of caution that you must first clinically evaluate that there are no macular pathologies like diabetic macular edema or age-related macular degeneration or any central serious chorioretinopathy, because then this evaluation of macula is no longer useful. The third important take-home message from this lecture is that instead of focusing on the retinal nerve fiber layer or the ganglion cell, you should look for concurrent and corresponding changes in the all three structures. That means look for changes in the retinal nerve fiber layer, look for corresponding changes in the neuroretinal rim, and corresponding changes in the ganglion cell complex. And that makes a very robust diagnosis of glaucoma because you can document that there are changes occurring in all three important structures. And for this, the best report currently available is a wide scan. These are 12 into 9 millimeter scans where you can image both the retinal nerve fiber layer and the macula, the ganglion cell complex in one wide scan. So this is very helpful to follow the topography of the defect, and you can, instead of doing two scans, you get both the ganglion cell, the retinal nerve fiber layer, and the neuroretinal rim in one scan. And here you can see an example of why this is useful. So this is a wide scan. And here you can see there is a retinal nerve fiber layer defect, which is going and merging with the ganglion cell loss in the macula. Here you can see the deviation map. This is the area of the macula. There is a ganglion cell damage here, and that is being incorporated and spreading from the disc to the macula. So in one image, you are able to get both the retinal nerve fiber defect as well as the defect in the ganglion cell complex. And this is diagnostic of glaucoma. You can see inferior RNFL defect and defect in the ganglion cell complex in the macula. And in this patient, you can see there is a superior RNFL defect and a defect in the ganglion cells in the superior temporal region. So there is corroboration of the retinal nerve fiber layer defect and the ganglion cell defect in the superior region obtained with a wide scan. And this gives you a very nice topographic understand that there is a defect which is glaucomatous, and you can confirm the diagnosis of glaucoma. Now, interpreting the OCT scan has already been covered, but I would like to present a different technique for evaluating the scan. So the first important thing is that you check the fundus image of the scan or the multicolor image. So here you can see there is a well-centered scan, and here you can see as compared to the superior part of the multicolor image inferiorly, a RNFL defect is visible. So your clinical impression is already that there is a RNFL defect visible here. Secondly, you see the boundary of the retinal nerve fiber layer. Now, this is very important whether the OCT machine has identified the boundary of the retinal nerve fiber layer. If there is an error in the boundary identification, then the entire OCT report goes as a fallacious report. So this now, the retinal nerve fiber layer boundary is correctly identified. Now we go to the three important structures, the neuroretinal rim. So here you can see this is the neuroretinal rim, and in the temporal inferior location, so this the normative database is in yellow, and this line shows the normative patient data, and here you can see the black line of the patient. It is dipping in the temporal inferior region. So it shows that there is a thinning of the neuroretinal rim in the temporal inferior region. Let us look at the corresponding region of the retinal nerve fiber layer. So here you can see there is a defect in the retinal nerve fiber layer. So inferotemporal rim is thin, and correspondingly there is a defect in the inferotemporal retinal nerve fiber layer. So you have already have two collaborations, NRR and RNFL is thin. Now let us look at the total retinal thickness. So here you already know that red yellow is thick and blue is thin. Now compare the superior macular thickness with the inferior macular thickness. You can see here there is less blue, and here there is a blue zone which is going from the macula to the optic disc. So here you know there is a difference in the thickness between the inferior part of the macula and the superior part of the macula, and that is very nicely shown in the hemisphere asymmetry. So like you have a glaucoma hemifield test, which is very important in the visual field. Here you have the total retinal thickness of the macula and the hemisphere asymmetry. That shows, these black spots show that definitely there is a thinning of the macula in the inferior part of the macula as compared to the superior part of the macula. And then you see this is the ganglion cell thickness imaging. This is the total retinal thickness. So this thin part of the macula, it is confirmed now that this is occurring due to loss of the retinal ganglion cell. You can see inferiorly, this area, there is a temporal loss of the retinal of the ganglion cell, and this is merging with the retinal nerve fiber layer loss. So now you have the all confirmations available clinically in RNFL defect. The RNFL boundary is clearly identified. You have a defect in the neuroretinal rim, corresponding defect in the retinal nerve fiber layer, corresponding inferior thinning of the macula, and corresponding inferotemporal loss of the ganglion cells. So this is a confirmed defect that this patient has got a glaucomatous defect, which can be confirmed on the OCT. So just to go through it again in a different case, number one, the fundus image well centered, and here already compare superior versus inferior. You can see dark band. So there is an inferior retinal nerve fiber layer defect. The topography shows that the RNFL boundary is correctly identified. Neuroretinal rim, you can see that there is a thinning of the temporal inferior neuroretinal rim, corresponding thinning of the retinal nerve fiber layer inferotemporal. You can see superior RNFL is normal. The total macular retina thickness, compare superior region with inferior region. Here you see this blue sector compared to this yellow sector. So there is a definite loss of the inferior macular thickness confirmed with the hemisphere asymmetry, the inferior black arrow as compared to the normal white. So there is an inferior loss of the retinal thickness in the macula, and ganglion cell imaging confirms that this loss of retinal thickness is due to loss of the ganglion cells. You can see this inferior loss of ganglion cell. Normally this is like a donut, and here you see the inferior part of the donut has been erased. there is loss of inferior ganglion cell. So with this 6-part steps, you have confirmed a diagnosis of glaucoma in this patient. So the next take-home message is that the best way to confirm glaucoma in a glaucoma suspect is to repeat the scanning after the first visit every 4 to 6 months. You see for progression of a suspicious area on the retinal nerve fiber layer, or you look for spread of the defect either from the ganglion cell or the retinal nerve fiber layer, from the macula to the retinal nerve fiber area, or from the retinal nerve fiber area to the macula, always ensuring that there is a good quality scan. So this is the best way to diagnose glaucoma. Follow up the patient over time, see for progression of the defects, either the retinal nerve fiber layer or the ganglion cell, maintaining always a good quality scan score. The next important thing is that many times you can get red areas on the OCT. So where to look for early defects on the OCT scan? And here I want to highlight a concept known as the macular vulnerability zone. So you are aware of the normal anatomy that the superior macular fibers go directly to the temporal part of the optic nerve, but fibers from the superior part of the macula and the inferior part of the macula, inferiorly they will go towards the inferior temporal part of the disc, and superiorly they will go to the superior temporal part of the disc. So this inferior temporal zone inside the macula is known as the most vulnerable zone, and this is the macular vulnerability zone. So anytime you're looking for defects in the ganglion cell, macula, or the retinal nerve fiber, focus on this inferior temporal aspect, right from the macula to the inferior temporal part of the optic disc. And here you can see there is a RNFL defect here, and you can see inferior part of the macula in this zone, there is a ganglion cell defect. Here again, you can see inferior temporal part of the macula. It will not cross the horizontal meridian and corroborating with the retinal nerve fiber layer. Here you can see superior part of the macula ganglion cell defect in the macular vulnerability zone, or RNFL defect. And again, you can see this defect RNFL and this defect in the macular vulnerability zone. So many times you will pick up early defects in the ganglion cell in this area of the macula, which is respecting the horizontal meridian. So you will see the defect starting in the temporal location for the ganglion cell loss, and gradually it will spread and you will see RNFL defect. So look for defects in the macular vulnerability zone for the ganglion cell loss early in glaucoma. The next take-home message is that when you want to identify early glaucoma, look at the temporal part of the macula not crossing the midline, and look for the inferior temporal and superior temporal retinal nerve fiber layer. So this zone here, this zone here, this zone, and this zone, these are the 4 zones which have the highest vulnerability, and this is where you will pick up RNFL defect. So if you have RNFL defects coming superiorly or inferiorly or nasally, there are no significance. Early glaucoma will have RNFL defects in these 4 sectors of the macular vulnerability zone. Now, a few points about taking the scan, because your optometrist takes the scan and you see the printout in the OPD, but that is a wrong thing to do. Capturing the scan requires adequate positioning, centration. Now, often there is a dry eye or a air conditioning that causes a tear film evaporation. So here you can put 1 drop of artificial tears and then take the scan. And you should ensure that you have done an evaluation of the fundus and checked out for any lenticular opacity before you do the scan. And this has already been covered, but again to highlight, any media opacity or dry eye can reduce the signal strength, and this is a different cutoff for different machines that you should be aware of. So this was one of my early patients referred to me, and you can see patient was diagnosed as glaucoma and using xylatan, and there is a well-defined inferior retinal nerve fiber layer defect on the OCT, and signal strength is 5 out of 10. So inferior RNFL defect, very nicely visible. And here is the scan done after cataract surgery 4 weeks later. Now you can see the in red area has disappeared and a healthy RNFL. So if there is a media opacity, it can lead to underestimation of the retinal nerve fiber layer. So if there is a cataract, always do the cataract surgery and then evaluate the baseline OCT, and you will be surprised how much of the retinal nerve fiber layer thickness can improve after cataract surgery. So this was a false positive diagnosis of glaucoma, and signal strength has improved from 5 out of 10 to 9 out of 10. And with that, the retinal nerve fiber layer has become normal. This becomes very important when you are following the patient over time to evaluate progression. And here you can see this patient, it was on follow-up. You can see this is a scan 2011 and this is a scan 2015. And patient was diagnosed, you can see very nicely, patient is progressing. There is a downward slope of the inferior retinal nerve fiber layer thickness, superior retinal thickness, and you can see all these parameters are marked as significant. So this report shows that there is a progression of the glaucoma with a loss of the retinal nerve fiber layer. But you can see what is important, which was not noted. Signal strength baseline is 7 out of 10. And here signal strength is 2 out of 10. So actually the progression is a pseudo progression which is occurring because patient is developing cataract, and that is impeding the signal, and that is causing a false underestimation of the retinal nerve fiber layer thickness and coming out as progression. And here you can see the parameters of the patient on follow-up. So patient started with 105 thickness or 82 average thickness. And after 5 years, it has decreased by 10 microns, 72 average thickness, and the inferior quadrant 105 to 85. So drastic reduction in the retinal nerve fiber layer thickness. But in addition to focusing on the RNFL thickness, focus on the signal strength. So you can see 7 on 10, 7 on 10, 6 on 10, and here 2 on 10. So this scan should ideally be discarded. You do the cataract surgery, and then you will see this will turn out normal again. So this is a pseudo progression due to loss of the signal strength because the patient developed cataract and not a progression. And that is why the OCT interpretation becomes flawed, because a very high percentage of OCT scans can have artifacts. So nearly 1/3 to half of the scans can have artifact. And therefore, in addition to knowing how to interpret the OCT scan, you first have to see whether OCT is reliable and there are artifacts. So there are basically 3 major types. The identification of the RNFL boundary is not correct. You have a block in signal underestimation, like I showed you, due to cataract, or you have an overestimation due to vitreoretinal interface abnormality. So always check the interface on the OCT scan and the RNFL boundary before you jump to interpreting the scan. Now here you can see patient diagnosed glaucoma because the optometrist is doing the scan and you are seeing the report. So instead of that, when the scan is being done, you should see where the algorithm has marked the retinal nerve fiber layer. Now, this defect is not due to glaucoma, it is due to wrong marking of the retinal nerve fiber layer. So once you identify this, you ask the operator to correctly mark the retinal nerve fiber layer. Now, it's a completely healthy retinal nerve fiber layer. So there can be wrongly marked RNFL boundary by the automated software of the OCT. You have to identify this before you interpret the OCT, correct it manually, and then only you start interpreting whether OCT is normal or abnormal. So this was a recent patient. You can see red RNFL defect. So there was a scotoma here. You can see caused by a large vitreous floater. So vitreous floater is adjacent to the disc, so you are getting a cutoff of the signal, and you can see sudden dip of the RNFL profile. So this is due to this floater on the disc, and this is on the spectralis underestimation. And the same patient on the cirrus, you can see this now the floater has come on the optic disc, and incidentally there was there in both the eyes. And you can see the neuroretinal thickness supranormal. So this is because this is interfering with the signal. So in such patient, it is not reliable. So you have to position the patient and take a different scan or take the macula scan, because the RNFL is being distorted by this vitreous floater. And of course, you have to check. If you're not sure, ask your retinal colleagues, like we have with us Dr. Rohan Chavla. And there's an epiretinal membrane. So this sort of abnormality, if you are picking up, this will lead to an overestimation of the retinal nerve fiber layer. So you have to check the interface between the retina and the vitreous. Any abnormality here, it is going to interfere and lead to overestimation of your retinal nerve fiber layer thickness. So if in doubt, ask your retina colleagues to check the macula. And another very important thing, this patient, 45-year-old lady, was referred to me as glaucoma because OCT scans were abnormal. So again, this patient has got a congenital disc anomaly, and this will not be in the normative database of the machine. So before you interpret the OCT, you have to check whether this will be in the normative database or no. So there is a false positive OCT diagnosing congenital disc anomalies. So don't take this into consideration. And in such patients, you should see the clinical picture, the visual field, and the ganglion cell analysis, and that will be completely normal. So the next take-home message is that before you interpret the OCT scan, check the signal strength at each visit. Make sure there is no cataract, no posterior capsule opacification, no dry eye. Always check on the OCT screen monitor where is the boundary marking of the retinal nerve fiber. Is this correct or no? Rule out interface abnormality, epiretinal membrane, vitreomacular traction, partial PVD, for these will cause overestimation of the RNFL. And a word of caution, don't interpret the RNFL thickness in eyes with congenital anomalies, because these are not in the normative database. So rely on the visual field on the ganglion cell if the macula is normal, not on the RNFL or the disc parameters for congenital disc abnormalities. And this Dr. Harsha has very nicely covered the interpretation of the OCT parameters. And I want to again reemphasize why you should focus on the total retinal thickness map, because this is independent of the database. So here the OCT is not comparing against the normative database. So you are getting a topographic image of what is normal and what is abnormal. So see the total thickness map. Always see the symmetry between right versus left and the superior versus inferior RNFL. And there should be concurrence between the thickness map on the OCT and the deviation map on the OCT. And a common thing you should be aware of is the shifting of the retinal nerve fiber layer peaks or bifid retinal nerve fiber layer. That is a physiological variation that can cause red disease on the OCT. So here you can see, whenever you start interpreting the OCT after seeing the parameters, focus on the RNFL thickness map. So here you can see yellow superior versus inferior. Yellow here, there is a blue zone here. Then compare right versus left. Here you can see loss in the inferior part of the right eye. So there is a blue zone here, and see whether it matches with the deviation map. So both these are matching. The blue RNFL defect between this yellow area matching concurrently with the deviation map. So that is important to pick up thickness map. And then you look at the various objective parameters that have already been covered in the OCT. And here you can see there's a bifid RNFL. This is a normal physiological variation, but sometimes because of this bifid layer, this trough can come in the red area. So sometimes it will mark this area as a RNFL defect. So that is not a RNFL defect. It is a wedge between the two peaks of bifid RNFL, which is a normal physiological variation. So you should be aware of this physiological variation and not label the patient as glaucoma if this dips, the trough dips in the red area. And of course, before commenting on the RNFL peaks, especially in patients with myopia, there'll be a temporal outward shifting of the peaks, and in hyperopia, there'll be a internal shifting of the peaks. So you will have healthy RNFL that is shifted, and this may cause a false positive result. So here you can see this patient with a slightly tilted disc. You can see healthy RNFL is visible, but the OCT machine has labeled it as outside normal limits. Why? Because this peak of the RNFL is shifted. It's a healthy RNFL, but slightly shifted towards the nasal area. Because of this, it has come into the red zone. So this is a shifting of the RNFL peak, absolutely normal, but OCT labels it as outside normal limits. And this is a common occurrence that you should be aware of. Again, to emphasize, always see the thickness map. So here you can see nice yellow here corroborating, but here you see in this yellow there is a blue streak. If you see that this TS cyanide map absolutely normal and quadrant absolutely normal and no superior defect on the OCT. So the OCT is giving you a normal topographic picture, but there is a suspicious blue zone visible here. So this is often missed, and on the fundus photograph, carefully see there is a RNFL defect visible here. So on clinical examination, there is a RNFL defect. On OCT, you may miss this because this is a summary parameter. There is no defect highlighted here. So this is called green disease. The OCT is showing green, but there is actually a RNFL defect. And if you are careful and you looked at the thickness map, you can see there was a blue streak here. So there was actually a RNFL defect identified on the total thickness map, not visible on the summary parameters. Then if you are following up a patient, don't change the machine because the average RNFL thickness is very different. You can see same device, same operator. The average RNFL thickness on the Zeiss was 90 micron, and the same patient on the Topcon, it was 106 micron. So different OCT machines are using different algorithm. When you do OCT on one particular machine on follow-up, don't change the machine. So that is the next take-home message on follow-up. Don't change the OCT machine. What you can do is, like you often have an upgraded version of the same manufacturer. So supposing you have a new machine of Series 6000 and previously you had a Series 5000, then you can import all the old patient data into the new machine and start following up the patient. What you should not do is that you are following up the patient on the Series OCT, and now next visit you start following on the spectralis. So do not change the manufacturer. You can, however, with the same manufacturer, use an upgraded machine and transport the old patient data. So this question is often debated. Should we focus on the retinal nerve fiber layer or should we focus on the ganglion cell complex? And as I explained earlier, they are part of the same axon, the ganglion cell body, dendrites, and the axon. So in many patients, you will get the retinal nerve fiber layer progression before ganglion cell loss. And in some patients, you will get ganglion cell progression before RNFL loss. This is more common in normal pressure glaucoma. So on follow-up, you have to image both the retinal nerve fiber layer as well as the ganglion cell complex, because you can have one defect occurring before the other, and both of these precede the visual field defects. So once you are able to show progression of the RNFL defect or the ganglion cell defect, it confirms diagnosis of glaucoma provided it is in the expected zone, the macular vulnerability zone. And then you can take a call on starting treatment with the patient. If you see progression documented and clinically also you are seeing signs of an RNFL defect enlarging, or some clinical signs like high IOP or pseudo exfoliation or other risk factors. Another parameter that you can evaluate on follow-up is the neuroretinal rim, and it is also known as the minimum rib width, the Brooks membrane opening minimum rib width on the spectralis machine. So this is basically a neuroretinal rim thinning visible on follow-up, and this is especially useful if you get artifacts affecting both the macula and the retinal nerve fiber layer. If you are following up a patient of myopia to distinguish from glaucoma because you are getting a thinning of the neuroretinal rim, many times neurological disorders will show atrophy of the retinal nerve fiber layer or the ganglion cell, but there will be no loss of neuroretinal rim tissue. If you're getting neuroretinal rim tissue loss, that is an important factor to distinguish non-glaucomatous optic atrophy from glaucoma. So in addition to RNFL ganglion cell, you should also focus on thinning of the neuroretinal rim on follow-up. So the next take-home message is that learn to image and follow up both the retinal nerve fiber layer, the ganglion cell, and the neuroretinal rim when you're seeing the progression of a glaucoma patient on the long term, and check for collaboration among all three factors. Always ensure that there is a good quality scan. You have taken 2 baseline images, and if you can document confirmed deterioration of the RNFL or the ganglion cell complex across 2 visits, that confirms progression, and then you can discuss with the patient and consider clinical examination, other risk factors, and have a discussion with the patient on starting treatment because you have documented structural progression of the optic nerve damage on the OCT. The OCT is basically useful for ocular hypertension, glaucoma suspects, or early cases of glaucoma, and it is better to follow up patients of moderate to advanced glaucoma on the visual field and not on OCT. However, you should know that in eyes with advanced glaucoma, you can follow up the patient and document changes in the ganglion cell complex because the RNFL is of no use after moderate to advanced glaucoma. It has reached the floor. You have no RNFL visible for follow-up. So advanced glaucoma, you can still use the ganglion cell imaging and show loss of the ganglion cell and follow up the patient of advanced glaucoma. But it is better to use perimetry for such patients and follow up with a 10-2 in patients with advanced glaucoma. So coming to the end with some case studies. So this was a 45-year-old surgeon referred to me for second opinion. So 3 years patient was using Travatan. IOP was normal, and you can see the reason because once you are having a doctor coming to you and you have such threatening optic nerve heads, please look at deep excavated cup. So clinically, definitely looks like glaucoma. But another problem was this patient got a HRT report. So HRT has marked 5 sectors as abnormal, the mood field regression analysis. But when you do the OCT, absolutely healthy retinal nerve fiber layer. So you could stop the medical therapy and ask the patient to be on follow-up. So never tell the patient that you don't have glaucoma and you don't need to come again. You tell the patient at this follow-up, your retinal nerve fiber layer is healthy. You do not seem to have glaucoma, but you have to come for lifelong follow-up at least once a year. That is the message to be given to the patient. So this was a patient, healthy RNFL, you rule out glaucoma, stop therapy. Now this is another patient. You can see patient presenting with suspected glaucoma, 56-year male, borderline IOP. And here you have to spend time on the photograph. So I showed to my residents and half of them say normal and half of them say abnormal. So they're not sure. And why they're not sure? Because they are used to looking at the cup. Cup disc ratio is okay. Left eye looks slightly suspicious. But what you have to focus again, there is a retinal nerve fiber layer defect here. So this can often be missed on clinical examination. Visual field nearly normal, no significant defect. But when you do the OCT, left eye, there is definitely an inferior thinning of the retinal nerve fiber. The entire quadrant is depicted as thin. So then you go back, left eye, you can see there is a collaboration. You can clinically, you were thinking there is an RNFL defect, and OCT has confirmed there is a defect. So structurally and on the OCT confirmed the RNFL defect. So you can start patient on treatment. So this is what is pre-perimetric glaucoma. There is a loss of the RNFL visual fields appearing normal, but retinal nerve fiber layer defect appearing on OCT, which you had already shown by a careful clinical examination on the fundus photograph. And again, if you take the multicolor photograph, you will definitely see this RNFL defect. So now you are sure this defect is not spurious, it is collaborating with your clinical information. So this is another patient. This is a doctor from our institute and referred as glaucoma, because you can see what we are used to is cup disc ratio. So cup disc ratio enlarged. So doctor, I think you have glaucoma. And again, slightly high IOPs were there, but CCT was high. And you can see in patients who have a asymmetry in the refractive error, you can have an abnormal size of the disc as compared to other eye. So this was just an aberration. This is a physiological cupping, more in one eye as compared to other eye. The OCT was absolutely healthy RNFL. So you can tell the doctor, no need to worry. It's just a physiological variation of the optic nerve head. You don't have any glaucoma. And a problem occurs many times. You see these young patients coming to you who are being put on therapy with a diagnosis of juvenile glaucoma, because you can see, again, we have been taught in our training large cup disc ratio. So when you see this clinically, very large cup disc ratio. So the alarm bell rings glaucoma. So again, this patient came to me and he was already put on Travertan with this large cup disc ratio. But remember, large cup disc ratio, clinically you can see healthy RNFL visible, but absolutely normal visual fields and absolutely normal RNFL. So I could stop the patient, stop Travertan, and just be on regular follow-up. So OCT helped to rule out glaucoma. Now, very interesting case. So patient came to OPD, visual field were normal, and he was missed. So we said, you don't seem to have glaucoma. It looks like surgery cupping fields are normal. So then we said, send the patient, but at least you get an OCT done. Now OCT right eye showed there is a dipping of the inferior RNFL. You can see the peak as compared to superior, it has dipped. And temporal inferior sector shows there is an abnormal finding. And then when we looked at the fundus photograph in detail, we could make out that there is an inferior RNFL defect between these two major blood vessels, and it is corroborating the slight notching of the neuroretinal rim. So we missed this clinical finding, but when we saw abnormal OCT, we held back the patient, we analyzed the fundus photograph and 90T, and then we could make out slight notching and this RNFL defect visible on the fundus photograph. So that is another take-home message, how we can improve our clinical skills. If you examine the patient and you feel it is normal, and you ask the OCT to be done for a suspicion, and the OCT shows an abnormality, you must go back and carefully re-examine the sector in which the OCT has labeled as an abnormality, and you will realize sometimes you have missed clinically the RNFL defect, the OCT is picked up, and that is how you become more alert in picking up clinical RNFL defects. So go back and check the RNFL in the sector which the OCT turned as abnormal. And finally, whenever you see defects on the OCT, for the best confirmation, you should do correlation of structure and function. So try to correlate the defect on the OCT also with the defect on perimetry. So this is patient from last week's OPD, 45-year-old male, IOP is 20 to 22, CCD 540 micron, and this is the fundus photograph. So if you see carefully, inferior neuroatrial rim and superior, there is a notching of the superior neuroatrial rim. So already there is a clinical suspicion something is going wrong. There is a RNFL defect visible here. So it's only with practice that you will be able to identify this RNFL defect, but there is definitely a notching of the neuroatrial rim which is occurring. So then this is the multicolor. Now you can see immediately there was a slight difficulty in diagnosing RNFL defect on multicolor image. Clearly, very nicely demarcated superior RNFL defect has become visible. So clinically now there's alarm bell. There is a superior RNFL defect visible on the multicolor photograph of the OCT. You are not so sure on the fundus photograph. You do the OCT scan, well-centered image, boundary correctly identified. You are already knowing superiority, there is something going wrong. Neuroatrial rim, temporal superior dip of the neuroatrial rim, superior inferior rim is absolutely normal. Superior rim, there is a loss. Corroborate with the RNFL loss, superior temporal RNFL loss, superior RNFL healthy. See the total macular thickness, this blue zone here, here blue zone is going towards the disc. So definitely more blue superiorly than inferiorly. Hemisphere asymmetry showing definitely loss of the superior macular thickness as compared to inferior. And then ganglion cell, you can see compare inferior temporal ganglion cell with superior temporal. Here you can see temporal loss of the ganglion cell causing the decrease in the macular thickness corresponding with superior RNFL, superior neuroatrial rim loss, and finally superior notching and inferior visual field defect. So this is a perfect correlation of structural superior loss with inferior visual field defect, and you will follow up all these parameters over time to see whether glaucoma treatment has stabilized, achieved target IOP, patient is stable or progressing. And finally, what to expect in the near future, very exciting advances in the OCT technology is called ROTA. So ROTA stands for retinal nerve fiber layer optical texture analysis. So this is a new algorithm which is being incorporated in the OCT. Brilliant work done by Dr. Chris Leong from Hong Kong. And you are able to very nicely see the architecture of early loss of the retinal nerve fiber layer with this technology. So this is the future which is going to come recently. And you're going to have the wide field swept source OCT being used, because here you can diagnose in one scan, you can take image of the disc, the macula, the RNFL, and also have an overlay of the vascular changes. So you have a loss of the vascular supply, loss of the retinal nerve fiber layer, corresponding changes in the ganglion cell and the neuroatrial rim, all being picked up with one scan, collaborating with the loss of the vasculature. So these two technologies, the wide field step source OCT with angio overlay and the retinal optical layer, optical texture analysis, are two very exciting technologies that will have increased use in the near future and improve our detection of retinal nerve fiber layer defects and ganglion cell complex abnormalities on the OCT. So to summarize what you have learned today, it is best to use the OCT to confirm what you are suspecting clinically. It can definitely help to rule out glaucoma or rule in glaucoma and confirm your clinical suspicion. Very useful in patients who are glaucoma suspects, large curved disc ratio, ocular hypertension, and early glaucoma. And also very useful in some patients who cannot perform perimetry or cannot perform it reliably. So there it becomes very handy as the only investigation. You are getting with the OCT a good baseline of the optic nerve and the RNFL ganglion cell to monitor change over time. Defects in the RNFL and ganglion cell can predict future functional loss on perimetry. Always use combined information, the RNFL, ganglion cell, neuroretinal rim. Don't use any structure in isolation because change in one can precede change in the other. And whenever you see a red OCT, don't start treatment. That is the most important message. Do not treat based on just an abnormal OCT alone because 1/3 or 50% of OCTs have artifacts. Always correlate defect on the OCT with clinical finding. When you follow up a patient, remember they can develop cataract over time. So always check signal strength. If you get an abnormal scan, always redo the scan and always check the alignment on the monitor. Don't just see the report of the OCT. You must learn to read the OCT artifacts. If you are in doubt, take a help of a retina consultant to see the ERM or vitreomacular traction. And remember, in high myopia, you can get a lot of false positive. Instead of the RNFL, focus on the neuroretinal rim, and if macula is normal, on the ganglion cell complex. So, although the OCT is not essential for diagnosis of glaucoma, it can definitely help you in the treatment and follow-up of glaucoma patient if you know when and how to use it, and if you know when it is not reliable. So use the OCT to complement your clinical examination. And these are some of the reference texts that are very helpful. I especially would like to mention this Atlas of Optical Coherence Tomography by Dr. Budhens, and this glaucoma imaging atlas from Heidelberg, and very nice OCT imaging with all the published studies from Dr. Ki-Ho Park. And go to the WGA.1 website and you will see instruction course on the OCT and many other clinical material available which you can learn how to interpret the OCT. So these are reference texts which are very useful for understanding the OCT. So I conclude my presentation and with a salute to our brave soldiers who guard us and while we continue in our routine daily activities. Jai Hind. Thank you very much.